All right, good morning, everyone. Thank you for coming to the DiaSorin Learning Lounge early in the morning. My name is Michelle Tabb. I'm the Chief Scientific Officer for DiaSorin. And I'm really excited to organize this workshop for you all today to talk about the new molecular diagnostic assays that we have for fungal pathogens. So before we get into both speakers, who are Dr. Greg Berry from Columbia and Dr. Jackie Chow from Multicare in Tacoma, Washington, I wanted to give you a little bit of background and baseline here for why we are talking about fungal pathogens and why it's so important that we have new tools available from DiaSorin in order to detect these pathogens. So just to set the stage, many of you who have been to the sessions so far, the scientific sessions, have heard about unmet needs in fungal diagnostics, have also heard about how molecular techniques are great for detecting these. And of course, there's the burden of healthcare-acquired infections. And right now, we actually have the convergence of these two things. We have Candida auris, which is the first fungal HAI. So it's a tremendous burden on the US healthcare system. And just some statistics, 1 in 31 patients that are hospitalized, or 1 in 43 probably has an HAI. And the risk factors are if you've had an invasive procedure of some kind, severe illness, and of course, if you've been treated with antimicrobials. Now, the medical costs of healthcare-acquired infections are $28 billion in the US. And if we just hone in on fungal diseases and their burden in the US, that's $7.2 billion annually, of course, split up between hospitalizations and outpatient visits. And 1.4 billion of those are due to Candida infections in general. So this is all Candidas, not just Candida auris. So there's been a new push and call to action, both by the WHO and the CDC, to identify some of these fungal pathogens and especially take care of surveillance for Candida auris. So it's a top priority for both CDC and WHO, and I want to draw your attention to this graphic, which is released from a priority fungal pathogens report from the WHO, which shows the critical group, high group, and medium group. And as you can see here in the critical group, Candida auris is right up there. That's our healthcare-acquired infection. But there's a lot of other Candidas on this list, both in the critical, high, and medium group. And so my reason for showing you this is just to once again say there's been a call to action. There's been a realization that we need, especially for things like Candida auris, to strengthen laboratory capacity and surveillance, to invest in R&D, as well as to make investments in public health, because these infections are increasing. And Candida auris in particular, the rates have increased by something like 5-fold if you take a look from before to after the pandemic. So this is a tremendous problem. So now let's talk about the systems that we have, just as a brief intro before I bring up our speakers today. And so this is the family of molecular diagnostic instruments that are now available from DiaSorin. Starting from the left, we have a point of care device that is in clinical trials right now. And then going all the way over to the right, we have our high throughput systems. And so I draw your attention to the two that are circled there in green, the LIAISON MDX, which is for targeted molecular diagnostic testing, and our new LIAISON PLEX system, which is for syndromic sample to answer testing. And so the first assay you'll hear about today from Dr. Berry is our Simplexa C auris Direct, which is an assay that runs on our LIAISON MDX system. This is the first FDA De Novo authorized assay of this kind. The reason it's a De Novo instead of a 510K clearance is because it's the first. And this assay uses an axilla groin swab in order to detect this pathogen and detect colonized patients who would then be at risk for invasive infections. So this is a tool for surveillance. And then the other fungal pathogen assay that we now have available is on our new LIAISON PLEX system, which you'll hear about later today from Dr. Chow. And this system is our syndromic customizable sample to answer system. It's a brand new system. And in this case, you're going to take a positive blood culture that you gram stain and identify that yeast is present and run in this system. And it can identify up to 16 different pathogens, fungal pathogens, and you can see there are a wide variety of the candidas plus the cryptococcus identifications. And so with that, I would like to just give a brief introduction of both of our speakers today before I have them come up. So our first speaker today is Dr. Greg Berry. He's an associate professor of pathology and cell biology at Columbia, and he serves as co-director of the Clinical Microbiology Service and associate director for the Center for Advanced Laboratory Medicine at New York Presbyterian Columbia University Irving Medical Center. And he specializes in the application of infectious diseases, testing for clinical diagnosis of disease and patient management. So he's going to talk about Candida auris today and its burden and its emergence, as well as show the performance data from the 510K clinical studies, the De Novo clinical studies for our Simplexa direct assay. And then Dr. Chow is our second speaker. He's the Technical Director of Infectious Diseases at Multicare Health System in Tacoma, Washington, where he has oversight of microbiology labs in 10 area hospitals, as well as 6 freestanding emergency rooms and more than 100 clinics. He specializes in emerging infectious diseases and antimicrobial resistance, and he's going to talk today about our new LIAISON PLEX system and his experience with the system, as well as show you performance data from our yeast blood culture assay. And so we'll bring up both speakers, and then we'll take questions at the end. And so without further ado, Dr. Berry.
Well, thank you, Dr. Tab, for that kind introduction. And thank you all for joining us today to discuss this very important topic of Candida auris. So today I'm going to talk a bit about this emerging public health threat and kind of give a basic background and also talk about one of the molecular assays that can be used for detection. So just to start with the agenda, first I want to do a clinical and epidemiological review of Candida auris quite briefly. I'm going to go over clinical lab challenges for detection, and then I want to introduce the assay again a little bit more in depth and also go over the clinical trial data for the De Novo submission. So Candida auris was first identified in 2009 in Japan, and since its first identification, it has spread worldwide as an emerging pathogen. And it's a type of yeast. The reason why is because it can cause severe illness and spread quickly among patients in healthcare facilities, which isn't the most common characteristics we see of yeast spreading like an HAI. And symptoms of Candida auris really depend on the type of infection, with more invasive infections obviously having more dire outcomes. And so I think I'm pretty convinced that Candida auris is quite a problem, and in fact, so is the CDC, because the CDC actually lists Candida auris as the second most important antimicrobial resistant threat in the US after resistant Campylobacter. And the reason this is the case is because Candida auris is frequently pan-resistant. In fact, in the United States, 90% of Candida auris isolates are resistant to fluconazole, with another 30% being resistant to amphotericin B. The other big issue is the colonization issue. So asymptomatic patients can carry and shed Candida auris from their skin. Now, while these colonized patients can get infection and are actually a 10% risk of infection, and they are the source of infection for the other patients who get infected in the hospital setting. And colonization currently cannot be effectively treated. So really the only way around this is in order to identify and then do proper infection control measures to keep spread from occurring. The other thing is an issue with increased prevalence and mortality. So 50% of clinical cases are bloodstream infections. And in the hospital, these bloodstream infections lead to a 30 to 60% mortality in bloodstream infection cases, with 1 in 3 patients dying within the first month of being diagnosed with an invasive infection. So quite serious and moves quite fast. And in the United States, we've actually seen quite an alarming spread. You can see here from the map, looking at the number of cases, over half of the states, by 2022, over half of the states in the United States have reported at least one case of Candida auris, with several states reporting many cases of Candida auris. And in fact, we see about 8,000 clinical and screening cases combined reported in 2022. So it's quite a rise if you think about the first patient being identified in 2009, and by 2022, we already have 8,000 identified cases in the United States. And Dr. Tab already went over this, but I think it's worth reiterating the fact that fungal diseases cost billions of dollars each year. And in fact, Candida is actually about 1.4 billion, and no doubt we're going to see this number increase with Candida auris's increasing frequency. So, talking about a global view and looking at Candida auris in general, here you see the global view of the map. You can basically see that you've seen Candida auris, and in blue, what you can see is transmission or multiple cases in these countries. So you've seen it basically spread across the whole planet. And when we look at a map of the United States, we can see that Candida auris, so in general, Candida auris is grouped genetically into 6 clades. And currently, we have 4 of the 6 clades in the United States. And because I practice in New York and I'm at Columbia, New York City, I tend to look at the New York data quite a bit, and we do have quite a few cases in New York. And as you can see, the first case was identified by public health surveillance back in 2016. But as of September 2024, there were 2,109 cases of clinical cultures. So these are patients that were suspected of having Candida and had a clinical culture sent and were diagnosed with Candida auris infection, and 2,722 cases identified through screening samples. In New York, almost all of these are South Asian clade 1, which is fluconazole resistant. And so you can see that through New York, we've seen quite a spread starting in 2013 at one clinical case, to our present state. And so I think that this brings up the point is, why is colonization testing so important, right? Well, I think I'll reiterate the fact that colonization of people, right, even though they may not get infected, they are reservoirs for infection for other patients, and 10% do get infected, right? So it's a major risk factor for invasive infection, with 1 in 3 patients dying that get an invasive infection. And again, there are no current decolonization strategies. So the only way in order to actually quell the spread of infection is to identify the bug and make sure that proper infection control measures are being followed. And I'll tell you why that is such a difficult issue as well. And a typical sample is a bilateral axilla and groin specimen. And so when we talk about infection control, in the hospital environment, Candida auris persists on many different surfaces if it's in a given environment. And it can actually persist on surfaces for up to 3 months. So this is, just a common hospital room, and these are places where you could typically find Candida auris in a room that hasn't been disinfected. And even if it has been disinfected, it's a really difficult bug to wipe out and get rid of. So standard infection control measures are things like standard hand hygiene, environmental disinfection, which again, this bug is quite difficult to get rid of even with disinfection, but also communication between different facilities in order to make sure that if a patient has Candida auris and they're being tracked, and also transmission-based precautions, right? So cohorting of patients, et cetera. But another important measure with infection control is screening, right? Because if you can screen a patient and find out that they have a Candida auris colonization through laboratory surveillance, you can then look at contacts that potentially were exposed and also avoid exposure moving forward. So that brings us to our next point, talking about current clinical lab challenges in Candida auris. So I think it's a good slide to start with because already it looks kind of challenging, right? You can kind of see there's a lot of different workflows here, one of which is a low complexity lab with differential media. You got a moderate high complexity lab with PCR and isolation, and you see mass spectrometry up here, MALDI-TOF, AST. Okay, anyway, I made my point. It's complicated, right? So let's break it down and take a look at what our options actually are. So first one was the chrome auger-based identification. So we look at culture. You can basically streak samples out onto chrome auger, and Candida auris samples will have a certain color. Now, while this is useful, it's by no means definitive, and it's also not that specific. So if you do identify a colony, you move on to the next phase and the next phase of identification. So it's not so straightforward. The next way to do this is biochemical identification. So this has been done for years in microbiology labs before MALDI-TOF in order to identify bacterial isolates. And this is definitely a way that you can identify yeasts, but in this case, it's pretty common that the biochemical identification for Candida auris is misidentified as another yeast. So that's a problem, especially if you're trying to identify every single patient so you can cohort and avoid the spread of infection. So another way to do this is doing standard culture and then doing MALDI-TOF, right? So this is mass spectrometry for identification of organisms. It works great. And the only issue is that it takes 72 hours to actually grow the culture. You need medical technologists who are well-versed in mycology to look at those mycology plates and identify those colonies. And that is a problem across the United States and across the world that, in a specialty of clinical microbiology, we have a shortage of staff. And we especially have a shortage of mycology staff. So another methodology, which has become more and more popular, right, is molecular identification. So these are PCR-based tests in general. And the nice thing about PCR is it's very sensitive and specific. But the main, I think, thing on top of this is that it's really quick, right? So it is more sensitive than culture-based methods, but it's also much, much quicker. Within a couple of hours, you have your result versus a few days. So that brings us to the topic of today. We're going to talk about the Simplexa Candida auris direct assay and talk about the data that went into the FDA submission for this assay. So just to give a very brief introduction, this is a real-time PCR assay that's intended for use on the LIAISON instrument, which is over here. This is used as a direct qualitative in vitro detection for Candida auris DNA from surveillance swabs. So this is swabs that are from bilateral axilla and groin specimens for patients that may be colonized. And the test is intended for use, really, it's used for infection control, so prevention and control of Candida auris infection in the healthcare setting, with the idea that rapid detection means you can have rapid action moving forward in order to do proper infection control measures. And so just a brief note on sample handling. So acceptable specimen types are the composite swab and bilateral axilla groin specimens. So these are collected specimens that could be stored at room temperature for 48 hours or up to 7 days in the fridge. And general transport media types are e-swabs, so liquid-based and liquid amines type or equivalent media. So it's liquid-based media. That's important for the next step. So how this gets set up is the workflow is you take that patient, how do I go back? There we go. Take that patient specimen and take 50 microliters out of it, put it into this sample prep solution, then take that sample prep solution and move to step 2. So you have a reaction mix, and then you have the sample. 50 microliters go into the sample well of the sample, and 50 microliters go into the reaction mix for the reaction. You close that little tinfoil little pizza wedge, and then it goes on the instrument, and it basically, in 105 minutes, you have a result. And again, no precise pipetting is needed for these steps. These are all pipettes that come in the kits, and little pipettes that are like calibrated, self-measured pipettes, and no extraction is done. And so just a word about the direct analytical performance of the assay. The LOD sensitivity done on clades 1 and clades 4 is between 127 to 260 CFUs per mil, so a pretty low LOD. Interfering substances were not seen, as well as cross-reactivity was not an issue, and basically analytical reactivity showed 100% detection of clades 1 through 4 by wet testing and detection of nucleate 5 by in silico testing. And reproducibility. So as a lab director, I can tell you reproducibility is really important. It looks really boring, but it's actually really, really important. When different people run the same thing in different places at different times, do they get the right answer or the wrong answer? And so I always take a moment to really look at this type of data, and really the most important box here is the total agreement across 3 sites for the different clades, and you can see a 99.8% overall reproducibility for the assay. So that means, to me as a lab director, I look at that and I say, this is easy to run, and it gets run properly over and over and over again. But this is the stuff I find the most interesting. So once all of that stuff is nailed down, because if you don't nail down that, you don't go anywhere, right? But if you do nail down all of those points, now we can talk about how it actually functions in the real world, in the clinical setting, right? So the clinical performance data for this particular submission, so I was one of the clinical trial sites at Columbia, then there was a site in Europe and Italy, and then there were 4 other sites in the United States. So across all 6 sites, we saw 2,020 specimens that were tested, 1,930 prospective with 90 pre-selected. An overall 2.8% prevalence rate in this prospective population, which is again pretty staggering considering that this pathogen was first identified in 2009. And the clinical comparator was culture and MALDI-TOF. So I said, really, that's the gold standard, but it takes 72 hours, right? So that was the clinical comparator that was done as standard of care at all these sites. And when we looked at how the assay performed, I think first I'll draw your eye down here to the positive percent agreement. So in general, the positive percent agreement for the assay versus MALDI-TOF and culture was 94.1%, and the negative percent agreement was 98.8%. But I think if any of you are like me, your eye goes there, right? What does that mean? What are these numbers? And there, but mostly here because it's bigger, right? So these are the numbers that were detected by the Simplexa Candida auris assay. So they called it Candida auris positive, but MALDI-TOF, culture in MALDI-TOF called it negative. So these are very important in a clinical study, trying to dig into what happened, what the difference is. And when we look at those 22, actually 21 of them were available for further testing. And when we looked, when they were further looked at with PCR and bidirectional sequencing, so a third arbiter for this result, 14 tested negative and 7 tested positive. So 7 of them were positive. Furthermore, a clinical standard of care PCR was done in several of these cases at several sites as well. They were following it up with PCR, and they also found that out of those, 7 additional tested positive. So when you look at those numbers, it kind of gets to the point where when you're doing culture and MALDI-TOF, you're already really close to, it's quite sensitive, but when you go into a PCR that's more sensitive, this is always the trick, trying to figure out who's right and who's wrong when you have 2 very sensitive tests. In general, we know PCR tends to be more sensitive, but it's always important to dig in and see what that difference is. And so with that, I'll just summarize and say, I think that we showed that Candida auris is a global source of severe antimicrobial resistant infections. It's been reported in 30 countries and has also spread rapidly across the United States. It spreads quickly in healthcare facilities, such as hospitals and nursing homes, and can lead to potentially deadly outbreaks. And so identification of patients that are colonized is absolutely essential in being able to move forward with controlling this healthcare-associated pathogen in order to keep people from getting infected and in order to quell transmission, right? And this is one assay, and actually it's the only assay that is PCR-based that's been actually cleared for De Novo FDA-granted submission and has gone through and is FDA-cleared to test for colonization. So with that, I'd like to thank you for your attention, and and I'd like to also thank my team in the Center for Advanced Laboratory Medicine at Columbia, the other clinical trial sites, if any of you are here, thank you, come and see me afterwards, and DiaSorin Scientific Affairs. So thank you for that, and with that, I will turn it over to my colleague, Dr. Chow.
Good morning. Thank you for coming, and hope you guys are enjoying IDWeek so far. Let's see. There we go. Perfect. Okay, so it's my pleasure to talk to you about my topic today, a new sample-to-answer molecular panels that detects yeast from positive blood cultures. This is my disclosure. So you may have heard of Veregene or even have experience with Veregene system. That is a benchtop technology that is capable of running multiple molecular panels for diagnosing different infectious diseases. And that would include bloodstream infection, respiratory illnesses, and GI diseases. And this platform here, LIAISON PLEX, is the next generation Veregene. It is also a sample-to-answer solution with multiple upgrades. First of all, it is smaller compared to the Veregene system. It has 6 modules with random access, meaning that you can load the samples as they come in. It has a streamlined workflow to reduce tech time, reduce hands-on time. The bidirectional interface would allow very efficient reporting of the results from the lab to the LIS and also eventually to the hospital information system. Now, from the lab perspective, there's another feature that lab directors will love, which is the room temp storage of the reagents, because we all know freezer space, refrigerator space, they are all very precious in the lab. Now, here in this slide, you will see the consumable cartridge. It's one single cartridge of about this size. Sorry, I have to hold my mic like this. It's about this size. Very easy to use. Instead of having the 3 separate components as the Veregene does, this one has one single cartridge. You just pop the lid open to expose the sample loading dock, and then you inject 300 microliter of the positive blood culture, and then you will scan 2 barcodes. One is for patient sample, the other one is a cartridge, and then you load it into the machine, press start. In about 2 hours, then you get the result. So it's very easy to use. Now, so far, LIAISON PLEX have two FDA-cleared panel. The first one was the respiratory PLEX panel. The other one is the yeast blood culture panel that I'm going to focus on today. There are a few more panels that are in development, including the gram-positive blood culture, the gram-negative blood culture, the GI panel, as well as the meningitis panel. So these are all panels that are going to be very helpful in terms of infectious disease diagnostics. So let me talk a little bit more about the yeast blood culture panel. It is a qualitative assay. Basically, it gives you a yes/no answer, detected or not detected. It is multiplex and is capable of detecting 14 targets that cover 16 different species of yeast that are known to cause bloodstream infection. Some of them probably look more familiar to you guys in terms of fungemia. For example, Candida albicans, tropicalis, persillosis, scabrata, Kunzii, those are the common, those are the frequent flyers. Of course, you have heard Dr. Barry's talk on Candida auris. It's also on the target. And then in addition, there are some other rare fungi or yeast that can also cause fungemia from time to time. Now, this panel does report the names. Oops, sorry. This panel does report the names that we are all familiar with, and of course, we are all aware that some of the organisms have been reclassified and given a very fancy name, like Nagasiomyces, Pichia, you name it. And I know what you're gonna ask me. Yes, I'm a microbiologist. No, I did not come up with all these names, so please don't come after me afterwards. Okay, so I think we all agree that the identification and differentiation of different yeast species is very important from the clinical perspective. Because of their high diversity, the resistance mechanism to antifungal and their resistance pattern can behave very differently depending on the species. For example, if you're a patient with C. Kunzii infection, you probably don't want to give him or her fluconazole because of the intrinsic resistance. Depending on the comorbidity and the past medical history of the patients, some of the yeast infection may be more common. So in oncology patients, transplant patients, C. cabrata infections tend to be a little bit more common than other yeast species. In patients with hematologic malignancy who have received fluconazole as prophylaxis, C. Kunzii infections tend to be a little bit more common. Now, you have, again, heard of C. auris and the clinical impact, the multi-drug resistance, or even pan resistance from Dr. Barry's talk. C. neoformans and C. gardii are the common flyers for immunocompromised patients. And then C. gardii can also cause infection in immunocompetent individuals as well. So now let's take a look at some of the clinical performance data. So the clinical study was actually conducted at 4 sites in the United States, designated on the map here. Let me see if there's it. So these 4 sites are geographically diverse, and the study was conducted between June and October in 2023. And the study was separated into 3 arms, and I'm gonna go through them one by one. So the first arm included 69 prospectively enrolled patient samples. And from the demographic perspective, most of patients were adults. And in terms of the gender, it's about 50-50 for male versus female. And in arm 2, we had the pre-selected patient samples. And these are the samples that DSRM were able to procure from different vendors that covers both positive and negatives. I believe we had 50 positives and 13 negatives, and that comes up with a total of 63 pre-selected clinical samples. Now, a total of 69 positive samples were run in one of the 4 sites, as I mentioned in the previous slide, and these are the outcome or the identification. Basically, C. cabrata, it's the top hit. We had 25 patient samples with C. cabrata, and followed by C. albicans, and then persillosis, tropicalis, and on the East Coast, we did have 5 patients positive for C. auris as well. The overall sensitivity was 100%, and the specificity was 99.4%. So based on the data, the performance of the fungal panel is extremely robust. And in the second arm, you can see the pattern is quite similar. We have the top three being identical as Gabrata, albicans, and Paracellosis. We also had 5 patients positive with Cryptococcus neoformans or C. gardii. And the overall PPA and MPA were both 100%. Now you may ask, from the previous slide, these specimens from patients, they were from the common yeast. And of course, we have a lot more targets on the panel. So in order to cover and test those targets, we also had arm 3, which consists of the contrived samples. So a total of 829 samples were collected over the past couple of years, and they were run in all 4 sites across the country. The overall valid rate is 99.7%, meaning that there is only very few invalid results when we run the test, and that means it's a very, very reliable test to run from the technical perspective. And the overall PPA is 100%, and the MPA is, again, it's close to 100%. So taken together, I think the clinical performance data have shown us the sensitivity and specificity of this new panel is extremely robust and reliable. Now that you've seen some of the clinical data, I'd like to point you to some of the analytical performance data. So this Yeast blood culture panel is designed for different blood culture system and their corresponding blood culture bottles. So as a result, 13 types of blood culture bottles were tested, and these 13 types of blood culture bottles came from 3 different major vendors, including Bactialert from bioMérieux, BDFX Bactec bottles from BD, and also VersaTrack from Thermo Fisher. In order to show the specificity of the probe targeting each species, we also had 5 different strains from each of the yeast species. So that comes up with a total of 70 different strains for the next part of the study. And as expected, all the targets were able to be detected as 100%. And then in terms of the limit of detection, it actually varies by target, and that is not uncommon. And the reason is even if you test the same species but with different strains, you're likely to find different LOD based on the nature of the bug. Cross-reactivity was also tested. There were 40 off-panel bacteria and 37 off-panel yeast being tested for cross-reactivity. And there were 2 circumstances that we find a little bit of cross-reactivity. And that was when you have a Candida pseudohumulonii, the Candida humulonii target will be able to pick it up. And then if you have a Yerroria deformans, it would also be picked up by the Yerroria labolytica or the Candida labolytica probe as well. But other than these cross-reactivity between very closely related species, we don't see any other significant cross-reactivity for the panel. And finally, interference testing was performed. There were 18 substances tested in this part of the study. 5 of them were endogenous, meaning that those are the materials or substances that you can find within the blood, including hemoglobin, bilirubin, and also triglycerides. And there were 13 exogenous substances that were tested. Most of them are antifungal, antimicrobial, antibiotics as well. And out of these 18 substances, there were 1 possible interference that was detected when you have a very high level of fluconazole in the sample. And I'm going to tell you a little bit more in the next slide. So this is a table that I obtained from the FDA website specific to diflucan, which is fluconazole. And basically, it shows the pharmacokinetic data. And when you have a very low dose and a short course of antifungal using fluconazole, the concentration of fluconazole in the plasma is actually very low, and it's even lower than the 8.3 mg per liter concentration that was tested fine using the fungal panel. And unless you have, when you have a higher dose with a longer duration of course, then your concentration in the plasma then will slowly increase, but still it is lower than the 25 mg per liter. So given this observation and pharmacokinetic data, once you have a high dose and a long course, that means you're already on the track of suspecting a fungal infection. So I would not think the interferon testing result here is going to be very relevant in our daily practice. So taken together, the LIAISON PLEX yeast blood culture panel is a sample to answer molecular panel that can be used to help diagnosing fungemia by detecting different yeast species from positive blood culture. And hopefully by identifying, differentiating different yeast species, it will be able to use this panel to help with selection of the appropriate treatment for our patients. So with this, I'd like to thank you for your attention. And again, thank you for the opportunity for me to speak here today. And I will be happy to take any questions.
Thank you, Drs. Chow and Dr. Berry. So hold on, let me go to the next slide here. So we have a couple of minutes for questions. So does anybody in the audience have any questions about Simplexa Candida auris or our LIAISON PLEX yeast blood culture assay? And if not, we at DiaSorin are down, I think it's on Sunset Boulevard in booth number 448. And so you can always come and visit us and ask us any questions after that as well. So, okay. Thank you all for coming today, and I wish you a good rest of ID Week.